So we'll move on to now the next treatment aspects of keratoconus, and we have different refractive modalities coming up, and I will talk on the first refractive modality, which will be on topoguided PRK and the nuances in its planning. So I'll try to keep it as brief and quick as possible. So essentially, we all know that topoguided PRK has now become a part of our standard armamentarium for care and is become very, very important in terms of how we are managing patients with mild to moderate keratoconus. We all know that the way topoguided PRK works is that there is a kind of a balance between smoothening as well as giving an overall regularization in the entire anterior cornea. So you have a combination of myopic ablation, that is flattening over the steepest part of the cone, and a hyperopic mid-peripheral ablation, which kind of steepens this area of the cone and giving an overall smoother anterior surface. So the general principles which we need to follow is that, as I mentioned, it's useful for mild to moderate keratoconus. When we are thinking of thickness itself, usually we include 450 microns as a minimum preoperative thickness. The other criteria which you could think of is that at the end of ablation, that is, before you start the cross-linking procedure with the epithelium off, you want to have a minimum thickness of 350. So that is the basic criteria as far as thickness. With regards to the refractive correction itself, it will depend on the thickness left and the spherical equivalent to the patient. We try to restrict between 50 to 60 microns. However, there are studies which have shown that you can ablate a little bit more and still be safe, because cross-linking is quite effective in these patients. The optical zone can be reduced from 6.5 to as low as 5.5 to save some tissue, and that will also help us in giving a more regular cornea to the patient. Again, emmetropia is never the goal. We also know that cross-linking also induces some flattening. So we are undercorrecting the patient to some extent. We have recently looked at our data of topoguided PRK patients, almost 500 of them. And when we analyzed them, we found that very, very rarely that patients were even reaching emmetropia or going into mild hyperopia. So because it was so rare, we see, and with the accelerated protocols, we don't really see too much prolonged flattening, which is very, very rare. So we have started reducing the amount of undercorrection that we are doing in these patients. And nowadays, 10 to 20% is more or less the undercorrection that we do. Treating on centered cones does work better. Having said that, doesn't mean that it doesn't work in decentered cones, and I'll show with a few examples later. What if you don't have access to a topoguided laser? Can we do conventional treatment or wavefront guided treatment? Some papers have shown that wavefront guided treatment also works. The only challenge is in these irregular corneas is to get a repeatable wavefront is the main challenge. But if you're able to get a repeatable wavefront, then maybe that can also be a useful modality, though topoguided would be the way to go. So I'll quickly take you all through the steps of planning. The most important thing after case selection is to ensure that you have repeatable scans taken before you go ahead with the treatment. So one of the important things that we look at is the mean deviation scores. And if it is below 0.1, it is more acceptable. If it is higher, as you saw in the previous cases, you try and remove the outliers and try and reduce the mean deviation score. Ideally, you would like to have 6 scans, but even 4 scans is sufficient. But you want to have scans which are repeatable and are closer alike to each other. With regards to the correction itself, of course, for the sphere, we have to go with the subjective refraction, but for the cylinder, we go more with the topographic cylinder, and the axis, especially the axis, we definitely go with what is given in topography. Well, once you start the planning, you would first set it on 0 power. This is not the default setting, but you bring it down to 0 power and look at the regularization itself and compare the regularization to the sagittite curvature and see if it makes sense. You want to be sure that the area where you're ablating is over the steepest part of the cornea, and the area which is having the arcuate hyperopic is just beyond or peripheral to the flatter area. So if this does not match with the sagittal curvature, I would be more hesitant in proceeding with the topoguided treatment. I would want you to repeat your scans, want you to repeat your refraction, and then only when you get an agreement between these two should you proceed. Subsequently, you would want to debulk the cylinder and depending on the amount of tissue left, you can debulk to the extent possible. The axis, usually I go ahead with the topographic axis. Whenever you have good correlation, it helps because both subjective and topographic cylinder in this case is very, very similar. But in some of the cases where it is not so similar, as in this case, almost 65-degree difference between diffraction and topography, you would want to compare the cylinder which is closest to what you see on the elevation map on the front surface. So here you see 165 on the topography, and this more or less correlates with the anterior float, the steepest part of the anterior float at 165. And that is the axis which I would prefer to key in when I'm planning my treatment. Subsequently, like I said, you can also add a small grade of hyperopia if the patient is accepting. This is a small technique to help in reducing the amount of ablation. So this patient was accepting a small +1, and when I add that +1, it comes down from a 60 micron ablation to a 50 micron ablation, and overall you're still able to smoothen the cornea and give an excellent outcome to the patient. These are just some good outcomes, examples which I'm showing you, and it is quite consistent. It's a very, very consistent procedure, and I find this more consistent than even intracorneal ring segments, because here you have a very planned outcome. You have an idea of what to expect, the amount of flattening, the amount of regularization, and we've seen in our case cohort that almost 36% of patients have more than one line of improvement in their best corrected visual acuity, and that is quite exciting. This is a patient with a centered cone where it is worked extremely well. You can see the best corrected visual acuity improving to 6.6. And this is a patient with a decentered cone. Now, initially in my cases, I was a little more concerned about using them on decentered cones, thinking it may not work as well. There were a couple of publications to support that as well. But we've made a comparison between our patients with centered and decentered cones and found the outcomes to be quite similar. So as long as the patient has a repeatable topography, repeatable refraction, you can have good outcomes in decentered cones as well. These are just a few more examples where you can see excellent improvement in the symmetry of the anterior cornea. It almost becomes a perfect symmetric bow tie, and there is in the central nipple cones, it works extremely well. If you just look at the sagittal curvature in the postoperative period, you wonder whether the patient even had keratoconus. The epithelium is a great masking agent, and removing the epithelium, how do you go about removing the epithelium is always a question. Until and unless you have an imaging system which can map at the level of Bowman's or the stroma, which is now becoming available, if you don't have that, you would do better to use a PTK rather than do a manual debridement of the epithelium, as the PTK would then leave behind an anterior surface which better mimics what you measured on topography. What is also exciting is with the advent of customized cross-linking, as Gitansha was mentioning, there are papers already, one from Canalopolis, where they have combined customized cross-linking with topo-guided treatments, which has further helped augment the results. While many of these questions are now becoming more and more clear with our experience building up with this modality of treatment, I think with the combination with customized cross-linking will make it even better. So it's definitely a promising procedure in early moderate keratoconus, and it definitely gives a certain degree of spectacle independence and also improves the overall quality of vision. Thank you so much for your kind attention.